also called as leukocytes, and we'll talk about general characteristics, leukopoiesis, or how the WBC cells are manufactured, what are the different types, granulocytes and agranulocytes. So this slide is actually belonging to the part that we already studied. So I already told you about blood transfusion, and just I'll run through this slide. Cross reaction. So every time you see an antibody meets the specific antigen, RBC will agglutinate and hemolyze, then that's called as a cross reaction. So that's why compatibility testing is done before blood transfusion. Okay, so we'll go to WBC leukocytes, general characteristics. They have organelles, they have nuclei, but they lack hemoglobin. Okay, so WBC, they have many organelles and nucleus, but they lack hemoglobin. And if you look at their function, chiefly, most important is defense. They protect the body. They are called as like the police force of the body, the WBC. And they remove toxins, debris, any damaged cells, and there are a lot less WBC than the RBC. RBCs are definitely more. Many of the WBCs are outside of the bloodstream also. They infiltrate into the tissues. You can find them in the lymphatic system, in the lymph nodes and the spleen. When you have inflamed tonsils, okay? When our tonsils are swollen, when we have pharyngitis right here, then you would find that there's increased activity of the WBCs right here at the tonsils, because they're trying to fight the bacterial infection in case of a strep throat. So they multiply more, and you can find them most of the time in the bloodstream or away outside the bloodstream, attacking the germs. So functional characters, they can migrate out of the bloodstream, the example that I gave right now, and that is called margination and diapedesis or emigration. So you may face a question like, what is diapedesis? What is diapedesis? So this particular term, it means that the white blood corpuscles or the WBC, they have the ability to come out of the bloodstream and invade into that particular tissue or organ which is infected, okay? And this process of moving out of the endothelial wall and entering into the tissue region to attack the bacteria or virus, that process is called emigration or diapedesis, moving out of the bloodstream to attack that foreign antigen. They're capable of amoeboid movement. So now, what is amoeboid movement? So when an organelle is able to thrust itself forward direction by putting forward its cytoplasmic process, just like an amoeba moves, that is called as amoeboid movement. Okay, so kind of like this. If this is the cell, then it would become like this and put the cytoplasmic process ahead and then move in that projectile motion. That's called amoeboid movement. And they're attracted to specific chemical stimuli, and that is positive chemotaxis. So when this is, suppose this is a WBC, okay, and then a foreign antigen, we call it A, that enters the body. So this antigen is going to release certain chemicals, and this WBC is going to move in that direction. Okay, taxis means movement, so responding to the chemical and going in that direction. The WBC itself also produces a lot of chemicals that would attract more WBC to come to that particular direction where you need action. Okay, so when a antigen or a foreign pathogen or a germ enters the body, you'll find that WBC not only responds to it by going in that direction, it also involves its community of other WBCs. It also tells others, okay, we all need to group together and go and march there and attack the pathogen. So that's why it has a positive chemotaxis, a positive movement towards the chemical stimuli. So diapedesis, emigration, the ability of the WBC to move through an intact capillary wall or a blood vessel into the tissue. This is what I explained just now. So from the blood vessel, it will, from the artery or the vein, it is going to move out and enter into the tissue region where it's going to act on the pathogen, okay? It's going to attack the bacteria there. So this act of moving out is emigration, and this process is explained as diapedesis. So if the question comes, what is diapedesis? You need to write emigration, or moving out from the bloodstream and going to the tissue region to attack the pathogen. WBCs have amoeboid movement for migration. So the movement just now that I drew and explained, they use that mechanism to move. Chemotaxis, the chemicals attract WBCs into certain areas of the body where they intend to go and act. Phagocytosis, the ability to engulf and digest the foreign material. So WBCs have a great role in phagocytosis. They will go and they will attack the pathogen and completely engulf it, completely swallow it, completely take it over, and then they have digestive enzymes that are going to disintegrate the pathogen, break it down, okay? So then major histocompatibility complex, MHC. What is the role of MHC? So what happens is our cells have MHC molecules, okay? Sorry. And these MHC molecules, they have like, you know, like antennas, okay? And when a foreign pathogen comes, this MHC has molecules, chemicals that will specialized peptide proteins that will, you know, identify whether the intruder or who has come to your house is a friend or it's an enemy. Okay, so the major histocompatibility complex is going to identify whether the intruder is a friend or an enemy. And then it's after knowing that, okay, either it's a friend means it's a self cell, own cell, it's not going to attack it, or it's going to be a foreigner. Okay, a foreign cell. So MHC that is present on the cells is going to present, they're called, you know, antigen presenting cells. This MHC is going to bear that and present it to the cell, whether it's a self cell or a foreign cell. And based on that, if it is a foreigner, it's an outsider, it's going to trigger an immune response towards it. It's going to an immune response will be created to attack the foreign cell. So that's the role of MHC. So 5 types under the microscope. So if you look under the microscope, when you do the labs, I think most likely they'll be using the Jameson stain. And then when you look, when you put the stain and you look under the microscopes, then you'll find granulocytes, and they have granules in cytoplasm. Well, to say that they have granules is like, it would be misleading, because actually those are like secretory vesicles and lysosomes. Okay, don't think that granules means like some grains over there. Okay, it's not grains, these are actually secretory vesicles and lysosomes, but we'll call them granules because even the agranulocytes that says lac granules, they also have very limited, less number of these secretory vesicles. Anyway, so granulocytes, they contain granules, and what are the different types? Basophils, eosinophils, and neutrophils. The mnemonics here, Ben has grains. Okay, Ben means B for basophils, eosinophils, and neutrophils. They have grains means granulocytes. This is just to help you so that you can remember which ones are granulocytes. And they are non-specific, and they're also called macrophages. So what is macrophage? We just discussed about macrophage. So what is microphage? So owing to their smaller structure and size, they are called as microphages. Okay, and they are non-specific. So non-specific is what? So there is a specific immunity and there is a non-specific. Non-specific means these ones, they can act on any kind of pathogen. Any pathogen that enters, any foreign antigen that comes, they are non-specific. They are not going to specifically act on bacteria. They can act on parasites, they can act on virus, they can act on fungi, they can act on bacteria, they can act on any foreign chemicals. So that is why they are non-specific. Now the agranulocytes, they lack granules, and they are the lymphocytes and the monocytes. And monocytes are macrophages. Macro means big. This one is micro. These three are micro. They are smaller. Monocytes especially are macrophages. They're actively phagocytic. Out of all of these, these ones are like, the first line of defense. When we go to the chapter on immunity, I will explain that. But the more aggressive kind of attack would be done by the lymphocytes. But that will come slowly. It will come slowly. There's a second line of defense. So that is why these ones will first come and try to attack. If they fail or if they need more force, and then these will be brought into action. Monocytes are also very deadly. They are big macrophages and they're actively phagocytic. They very aggressively attack the foreign pathogen. Regulation of WBC production. So how do we get WBC in our body? How is it formed? In case of kids, we have the thymus gland, that's the endocrine gland, and it promotes the differentiation of T cells. Okay, so thymus gland, by the age of 8 or 10, or before the onset of becoming a teenager, this would ultimately disintegrate or degenerate. The thymus gland will cease to perform its function, and in the adult stage you'll see the red bone marrow taking over, and then your immunity increasing. Okay, so that's why one of the reasons is that when we are small, when we are like in our age 5, 6, 7 and all, we suffer a lot of infections because our immune system has not developed that well. Now, in case of adults, exposure to foreign antigens, toxins, causes the lymphocyte production. So here's the distinction. What happens in case of kids and what happens in adults? In kids, thymus would cause the differentiation of the T cells, whereas in adults, you would find when the foreign bacteria or pathogen or foreign toxic substances enter into our body, they trigger the lymphocyte production. Now, the CSF, that is colony stimulating factor, that also helps to regulate WBC. Who are they? They could be multi-CSF, or it could be GM-CSF, or it could be G-CSF. So what is G? G stands for granulocyte, okay? Granulocytes, and this would be the monocyte, and this is only granulocyte CSF. So G-CSF means all the granulocytes CSF. This one is all the granulocytes and monocyte CSF, and this is a combination of all of them. These are the colony stimulating factors that would regulate WBC. And always there is chemical communication between lymphocytes and other WBC. By other WBC, what do I mean? I mean that neutrophils, eosinophils, basophils, all of these, they communicate with lymphocytes. Okay, so there is mutual communication. Like I said, if neutrophils, basophils, and eosinophils, they are not able to handle the pathogen, they would ask for greater force. Okay, so it's like, initially when there's something goes wrong, then you have the police force, the local police responding to the situation. But then you see that they need more force and they need more intense kind of defense. Then they call the FBI, or they call the fingerprinting forensic science department people, or they call for backup. So that is the same way how it works. The first line of defense tries to go and attack the pathogen. It fails, or it is not able to handle it. It needs for more backup, and then how will it communicate? It will communicate, that is the chemical communication between lymphocytes and other WBC. They ask the lymphocytes to come over and help. So active lymphocytes, they release multi-CSF, igniting non-specific defense. So just like the other WBC cells, they call lymphocytes for help. In the same way, lymphocyte also will release this multi-CSF, and it will trigger non-specific. What do you mean by non-specific defense? That means the neutrophils, eosinophils, basophils, they are non-specific defense cells. So those are activated also. So it is mutually, helping each other, symbiotic relationship. So the small WBC cells help lymphocytes, T and B cells, and the T and B cells, lymphocytes, they help the small WBC cells. Leukopoiesis, or making WBC, how is it formed? How is it manufactured? So stem cells that form, again we go back to stem cells, hemocytoblast, like we read about the RBC. It all begins with the hemocytoblast, or the progenitor, the mother cells. So stem cells that form WBC originate in the red bone marrow, and they begin as hemocytoblast, stem cell. Okay, so blood cell and blast is the progenitor or the mother cell. Then they become a colony forming unit, and each colony forming unit may bind to a different colony stimulating factor, or CSF, that I just explained, and they will differentiate into one of the WBC types. So over here you can find that hemocytoblast, first classification over here, when it divides, you'll find myeloid stem cell, and it will form lymphoid stem cell. The lymphoid stem cell will proceed in this direction, lymphoblast, okay, and then ultimately it will lead to lymphocytes, and that will differentiate into plasma cells. Now the myeloid stem cell, it will also proceed in this direction, and it will give rise to the other granular leukocytes, that is eosinophils, basophils, neutrophils. A branch of them will also form monocytes, okay, and that will, monocyte we know, that will form the macrophage, that is phagocytic in nature. You don't have to remember these classification or these steps. You just have to remember that it begins with hemocytoblast, divides into myeloid stem cell and lymphoid stem cell. From the word lymphoid, you can know that is ending up into lymphocytes, and from the term this myeloid, it will proceed in this direction to give rise to the other granular leukocytes. And CSF may be released by mature lymphocytes or macrophages in response to tissue damage or infection. So remember, whenever there is an infection, whenever somebody catches some kind of a viral infection, then you will find that there's, in response to that infection, the immune system is immediately activated or triggered. So neutrophils, if you look at them, this is how they look under the microscope. It looks like, you know, a beaded necklace, like a pearl necklace with beads. So most common type of WBC, it is dense and segmented nucleus and 2 to 5 lobes like beads. So if you look under the microscope, it would look like this. Okay, so that would be with beads, like a necklace, like pearl necklace. Okay, so it has polymorphonuclear leukocytes. It is called as polymorphonuclear, okay, because how the nucleus, it is segmented, okay, it looks like different segments. 50 to 70% of WBC in the blood, cytoplasm is packed with granules and lysosomal enzymes and bactericidal compounds. So when I talk about WBC, you will hear a number of times this one, lysosomal enzymes. Okay, why do I talk about lysosomal enzymes? Is because of their activity in, you know, making the pathogen disintegrate, attacking the pathogen, causing lysis. So that is why these lysosomal enzymes are very important, and they have bactericidal compounds that are chemically going to deactivate the pathogen. It appears as if they have a segmented nucleus, like I showed you. Commonly referred to as polymorphonucleosides, many different shaped nuclear cells. The more the WBCs age, the more segments the nucleus has. This is important. This point is important. So the more the WBCs age, the more number of segments you're going to find. And they're the first to arrive at the injury site. They are active phagocytic cells. They attack the bacteria that are marked with antibodies or complement proteins. So what are complement proteins? These are like plasma proteins, okay, involved in this process. And then there is a respiratory burst of hydrogen peroxide defensins, okay? And they cause degranulation. So what is degranulation? This is also important. So what exactly happens? When a pathogen comes, the first people to arrive there, the first cops to arrive there are the neutrophils. Once they come, okay, and they recognize that this is a foreign pathogen, there would be an intense surge of activity. You'll find that there is lysosomal activity, lytic enzymes would be discharged, there is a respiratory burst of hydrogen peroxide, there is defensin enzymes being released, and it will also cause degranulation. That means the grains that hold these chemicals and enzymes are opened. The degranulation, that means they are no longer granules, they open up and they discharge these chemicals. Okay, so neutrophils will cause other neutrophils, that these chemicals will also cause other neutrophils to open up their granules and discharge the chemical or the enzymes, so that they are all in unison to act on the pathogen and kill it, actively attacking it. When actively attacking a bacteria, neutrophil releases prostaglandins and leukotrienes. So these are the two important ones also that it does. And what does prostaglandin do? It does a lot of inflammation. So here you see it increases capillary permeability and increases inflammation. And leukotrienes are hormones that attract other phagocytes and coordinate immune response. So, they try to, for the, it's not the appropriate word, like they gang up against the enemy, they group up, okay, and they form they try to attack it, and they form a union, bring in more WBC cells, okay, leukotrienes invite more to come in, attract other phagocytes, come on, get together, there's an enemy, we need to attack it, that kind of a thing. And then they increase inflammation. So what has inflammation got to do here? When you are talking about inflammation, means it is increasing capillary permeability, it is causing dilation, okay, it is increasing, expanding and causing more dilation, so that more cells, more WBC cells can come and they can reach the site of the infection, the injury. The neutrophils understand how crucial it is, the first initial point when the enemy comes, how crucial it is to attack it immediately without any delay. So if you see over here, I talked about the more the segments the nucleus has, the more is the WBC's age. So this picture I'm talking about, you can see over here, it is more segmented, and that's why it's an older cell. And this is more like a band. You can't see much of segmentation, so that's a younger cell. So they are the first line of defense when foreign material enters the body, okay, either through a puncture of a blood vessel or through wounds, or you cut your finger through with the use of a kitchen knife. So neutrophils have oxidizing enzymes like hydrogen peroxide, and they destroy the bacteria with the help of lysosomal enzymes and defensins and oxidants, and they phagocytize the bacteria completely. A high number of neutrophils will indicate bacterial infection. So if you go for a blood test in a lab and then you see that your neutrophil levels is high, maybe that's temporary, because you may had a recent cold infection or a bacterial infection or a strep throat, and that's why there is increased activity of neutrophils in your body, and that would show up in the blood test. So coming to the eosinophils, okay, and they contain, it's when you look under the microscope, it will be easy for you to distinguish the blood cells. Why? Because when you look at the neutrophils, you'll see that under the microscope, they look like a necklace. Pearl beaded necklace. For eosinophils, you see that it is because it stains with the eosin stain, a little orangish, pinkish. So you can immediately spot and know that, okay, this is an eosinophil. It's the easiest to detect because of the pinkish color of the stain. It's 2 to 5% present, and it takes up also the acidic dye, so it's also called acidophils. It contains a bilobed nucleus. Look at the nucleus having 2 lobes, that's why it's called bilobed nucleus, and it contains the reddish orange granules. When there is a parasitic infection, it is elevated because of this infection, or allergies, as they are sensitive to allergens, okay? And primary mode of attack is exocytosis of the toxic compound. So what especially happens is, suppose a parasite has entered into your body, like a roundworm or a hookworm infection. Maybe you ate some food in a restaurant which is not cooked well. So that's the way how the worms will enter into your body. Immediately your eosinophils number will increase, because they get into the they trigger this immune response, and they jump into the warfare to destroy the parasitic worms. And they do this by a mechanism called exocytosis, where they'll try to burst open those vesicles and they will attack the parasite. In case of allergies also, you will find that eosinophils also get triggered, and they phagocytize antigen antibody complexes. Antigens, as you know, they will trigger an immune response. Antibody sticks to the antigen and covers it up completely, and it produces a lot of enzymes that reduce also inflammation. So while neutrophil contains those enzymes that will increase inflammation, this one also tries to reduce the inflammation. Next is basophil. They normally are 0 to 1%, and they contain an S-shaped nucleus. In this picture, it's not so clear, but it has a S-shaped nucleus, and it is covered by purple or dark blue distinct granules. Granules contain chemicals like histamine that dilates the blood vessels, and heparin that prevents blood clotting. So one anti-blood clotting agent is heparin, and histamine that dilates the blood vessels. So basically, basophils are involved in anticoagulation and creating inflammation, okay? And they work together with mast cells in the tissues to increase inflammation. So you might go back and look at a question: is inflammation a good thing or a bad thing? That's a good question. Is inflammation good or bad? Well, inflammation, I would say, is good for our body because it would not allow the infection to spread. It will cordon off that particular area, and it would invite more and more cells to come and act on that specific region. But inflammation for a prolonged period of time, like it becomes chronic, it's always causing inflammation, is not good. Then you need to go to the source of it and see why this inflammation is constantly staying in the body. And people who have arthritis or rheumatoid arthritis, or people who have obesity, what happens is whatever we take in, the chemicals inside our body, that keeps our body in a constant state of inflammation, and then we get this aches and sores. Anaphylactic shock. In severe allergies, basophils are activated, okay? Like suppose you get a bee sting, or you have taken peanuts, you're allergic to peanuts or something. What is exactly happening? An antigen will bind to the basophil and cause them to degranulate in the bloodstream. Again, we come to this term degranulation, causing a release of histamine. So basically, the basophils, they are having histamine, okay? And we know that histamine causes inflammation. So now when you take peanut butter, okay, and that enters into your body, it's going to cause the basophils to degranulate. That means to kind of rupture and release histamine, and that would cause tremendous inflammation. And the fact that it happens, you know, so strongly and so drastically, that would result in bronchial constriction, and sometimes people have hives, and it causes blood vessel dilation. Some people have, you know, itching in the throat. All of these are symptoms that there is a great release of histamine because there's some allergen that has entered into our body, and that is triggering a massive response because of degranulation of the basophils and the discharge or the release of histamine, and that histamine is bringing about inflammation. You have tears in your eyes. Some children have a runny nose. Go to the next one, monocytes. So type of organocytes, and they are approximately 3 to 8% in the blood. They are 3 times the size of a RBC, and it's very clear to see they have a horseshoe like this, a horseshoe shaped nucleus, or you can also say that it is a kidney bean shaped nucleus, and they are again big time phagocytic WBC, very powerful, okay? And they transform into what we call as macrophages. So they can undergo diapedesis. That means they can also move out of the bloodstream, and they can wander around, reach the tissues and attack the pathogens. Once they leave the bloodstream and reside in the tissue, now they are called as macrophages. So when they leave the bloodstream and they go to the tissue and they start attacking that particular pathogen stuck or hiding in that tissue, now we are going to call them as macrophages. Macro means big, and they're very aggressive phagocytes. Okay, the way they move there is diapetes movement, and elevated in chronic or subacute infection. So whenever the infection is there, you'll find there is a surge of these monocyte activity. So when they go to the different tissues and they work there, what do we call them? Their name changes, right? We call them monocytes as macrophages when they enter into the tissue. So what we call them is Kupffer cells in liver, microglia when they enter into the brain, Langerhans cells if they are in the skin, and skin is an organ also. So osteoclast cells if they are in the bone, and alveolar macrophages when they are in the lung. Lymphocytes, they make about 20 to 40% of WBC, and nucleus is almost the size of the entire cell. That means if this is the cell, then the nucleus would be almost the size of the cell. And you would find there's a thin halo, a thin layer or a thin halo of cytoplasm just at the boundary. Okay, and there are small and large lymphocytes. There are three major types. T cells, the most powerful, cell-mediated or specific immunity. They act on target pathogens, target antigens. B cells, they make antibodies. We call this as the humoral immunity, and they are activated B cells that differentiate into plasma cells that synthesize and secrete the antibodies, and they can destroy the antigens anywhere in the body. So B cells, remember, they are linked up with secreting antibodies, and T cells, they are the specific immunity. Natural killer cells or the NK cells, so they like scan the body and they survey the body, and if they find anything that are abnormal, they try to attack it. So they are the immune surveillance system, okay, and they try to prevent cancer. So when we get older, some cancers happen in the old age because naturally these natural killer cells they become worn out, and they don't function the way they should. So if there is any cancerous cells or any foreign viruses that are capable of causing cancer, they are missed, they are skipped by the NK cells. So mnemonics again for WBC: never let monkeys eat banana. Okay, so you're going to remember it through this. Never stands for neutrophil, let is lymphocyte, monkeys eat banana. Why? Highest percentage to lowest percentage. This is the percentage with which they occur in our body, from the highest level percentage to the lowest one. Differential WBC count. Okay. Sorry. Example, so if you have increased neutrophils, that is a bacterial infection. If there is increased eosinophils, there is an allergy, or there is a hookworm or a roundworm or a tapeworm infection. If it is increased monocytes, it's a chronic infection and subacute infection. If it's increased basophils, chronic inflammation of the body. So if you get these increased numbers in your blood test, when you go to the pathology test, then you will know what are the conditions and why it is happening. Abnormalities, so leukopenia, that is too few WBC, okay, and why it could happen: because of lead or arsenic or mercury poisoning, radiation sickness, measles, mumps, chickenpox, and elevated risk for infection. So that is when this level will go down. Or sometimes in some people they just naturally have less number of WBC, but they are more prone to infection. Leukocytosis, that's too many WBC, and that level will increase when you are not drinking enough water, or you're going through emotional disturbance, some kind of mental, you're upset or you're frustrated for a period of time, like you're going into depression. That would increase the WBC, and then infection and allergies and cancer, and definitely in cancer the WBC count would be very, very high, okay, greater than 10K. So if you go to the lab and you see that your WBC is like 11,000, don't panic, Okay, if you see it's 13,000 or 14,000, don't panic. Everything is not cancer. Okay, for something to be cancer, it could be like, I don't want to give a number, but it should be like super high. Okay, super 50,000, 60,000, that's like super high. And also it depends on the stage of the cancer. So, but don't panic if you see like 13,000, 14,000, say, oh, my anatomy class taught me that if it's more than 10,000, it's cancer. No, it is not. It could be infection. It could be allergies. It could be you didn't drink sufficient water, or just that you are going through stress, or you didn't sleep well. So leukemia, the cancer of hematopoietic tissue. So what happens when this tissue that is actually responsible for manufacturing or producing these immune cells, what happens when this tissue itself breaks down? That's the cancer of the hematopoietic tissue. Okay, so that means this whole process of hemocytoblast differentiating and dividing and forming these cells, this whole mechanism would have a total crash or a breakdown. So myeloid leukemia, I've already told you that the term myeloid comes from red bone marrow. So myeloid leukemia, that is uncontrollable granulocyte production, and it could be either AML or it could be CML. Okay, so A stands for acute myeloid leukemia, or it could be chronic. C stands for chronic, so chronic myeloid leukemia. These are the two types it could form. Or it could be a lymphoid leukemia. Okay, so you'll find that this pathway is disrupted. Uncontrollable production of the cancerous cells takes over bone marrow cells. So this leads to a decrease in erythrocytes, platelets, and it's going to have consequence. If this mechanism fails, you'll find that there is anemia, there is hemorrhage, there is infection. So a person will begin to show signs of these anemia, hemorrhage, and infection for a prolonged period of time, and then no medicines are working, and it's happening again and again and again, and the person is sick and fatigued, because anemia means a lot of fatigue, and feeling very weak. And that's when they go to the doctor and they do a blood test, and all of these things are detected. So by the end of these number of slides, you should be able to know what is diabetes, what is chemotaxis, leukocytosis, leukopenia, colony stimulating factors, granulocyte versus agranulocyte, and leukemia. We discussed each one of them. So we will go to the next slide. Platelets are also called as thrombocytes. Okay, so we talked about RBC, we talked about WBC, the granulocytes and the granulocytes. Now let's go to the blood platelets or the thrombocytes. And blood platelets, their most important work, their role is in clotting. They are not cells, they are disc-shaped cell fragments. Okay, so we are not going to typically call them as a cell, but rather a cell fragment or a broken piece. So megakaryocytes split off and form little segments known as platelets. So now you see, we again go back to the stem cell, that is a hemocytoblast over here, and that's the mother cell, and from there it will differentiate into a megakaryoblast. Mega means large, karyo means nucleus, and blast, okay, from the progenitor cell. This one is ultimately going to form a promegakaryocyte and then a megakaryocyte, and then it will shred off into platelets. So what happens is, over here, you see over here there are more number of dots. Can you see? More number of granules are here. Over here, you can see there is a dilution of those, and those granules are not to be seen. So what exactly happens at this stage is it begins to lose its granules. It begins to lose its cytoplasm as small packets. Okay, it forms small packets of cytoplasm, and then it gives away, releases those packets, and those packets are called as platelets. Okay, so that is why we are going to use the term cell fragments. This is going to shred, and it is going to, like a paper is shredded, it's going to shred and give away small packets. So, and its function is blood clotting. Functions: they release chemicals and enzymes for clotting process. Who does this? This is done by the platelets. forming temporary patch in the walls of the damaged blood vessels, and then clump at injury site, forming a platelet plug that slows the blood loss while clotting happens, reducing the size of a break in a vessel. They have actin, myosin, platelet filaments contract to shrink the clot and reduce the size of the break. So let me explain to you, if this is a blood platelet, what it is going to do, what the work of the blood platelet is. Whenever there is a tissue break or a rupture, these blood platelets, they are going to come and they're going to release, first of all, they're going to release a lot of chemicals. Okay, they're going to release chemicals. They'll try to make a temporary patch, stitch it as best as they can do. They will try to create a platelet plug and they will try to heal up the damage. Okay, they close the damage as best as they can. They have mechanism to do it because they have those chemicals, they have those hormones, they have those enzymes, they have those filaments, they have vasoconstrictor with them. They can close up the wound. If it is a small prick or a small cut, these platelet plugs would be effective. Okay, but if it is a deeper wound or a big cut with a knife, or it's a serious wound or whatever, these would definitely not be able to fill it up, or the plug would definitely fail. And this platelet plug is not going to stop the entire damage, but it's an initial attempt by the blood platelets that it's like do something rather than not do anything. So they try to do something, and that is how they bring about the platelet plug. So you might ask me that ultimately we are going to form the clot. So what is the point of having a platelet plug right there? Because clot is going to take some time. And by the time the clot appears, you would have lost a lot of blood. And we don't want that. And that is why immediately we first go and have a platelet plug and try to seal the wound. It is not successful 100%, and that is why it ceases, we stop it, and then we look to the clot, and then the clot formation begins. I hope this explains. So what all it does, it reduces the size of the break in a vessel wall. Okay, and they have actin and myosin that help it. Platelet filaments also contract to shrink the clot and reduce the size. Everything that they do is to repair the damage that is done. So platelet production, how is it formed? Again, we go to red bone marrow. So thrombocytopoiesis, that is the process. Okay, thrombocytes, that is thrombocytopoiesis. This is the mechanism how they are formed from the red bone marrow, and these are basically megakaryocytes, mega having large nucleus, and that manufacture proteins, enzymes, and they release the platelets. Role of this activity is influenced by the thrombopoietin hormone. This guy is released by the kidney, and then interleukin 6 and multi-CSF. All of these help. I already talked about multi-CSF. So all of these help in the production of the platelets, okay, from the red bone marrow. So remember these things, they help in stimulating the production of platelets or the formation of platelets. What is their general characteristic? This is their count, and they contain microtubules and actin for movement. And these are the chemicals that they have, very, very important chemicals. They have ADP, that is adenosine diphosphate, and that is released by the platelets. It binds to the receptors of other platelets. They attract more platelets to the area, and they stimulate, again, this term platelet degranulation. That means the release of the secretions that are contained in those platelets, degranulation. Plavix inhibits blood clotting by binding to the receptor before ADP does. So even before ADP gets into the work, Plavix starts its work. And then they secrete serotonin. That is stored in the platelets. It acts as a good vasoconstrictor. What is vasoconstrictor? It tries to constrict the blood vessels. Wherever there is a big opening or a wound, this serotonin would go there and try to make it like this. Okay, it would constrict and bring them closer together, try to close the gap and it would cause vasoconstriction, and it also triggers the smooth muscle to contract and bring it together, to close the gap, to seal the wound. Then there is thromboxane A2, that's a prostaglandin. It is produced also by the platelets, and it promotes platelet aggregation and degranulation. These two terms are important, and it also does vasoconstriction. What is aggregation? That is bringing more and more platelets to get attracted to that site and form kind of a clump there. Degranulation, causing them to open up and discharge their chemicals, and vasoconstriction, constricting those blood vessels and trying to close the gap. All of these work is done by thromboxane. Serotonin, vasoconstrictor. ADP, that will bind the receptors of other platelets, trying to cause aggregation of the platelets. Aggregation means bringing them together, making a crowd of platelets at that site. So these chemicals are present in the platelets, and when the injury happens, these are released for activity. Numbers and term that you should know: thrombocytes, this is their number, and if it is too many platelets, it happens in case of cancers, anemia, hemorrhage, thrombocytosis, or thrombocytopenia, that is too few platelets. It could be because you're not taking your green vegetables, so vitamin B12 deficiency, and systemic bacterial or viral infection. Systemic means like it's moving through your organ systems, and then leukemia or chemotherapy. During these stages also you will find too few platelets. Blood vessels. Blood vessels are lined with simple squamous cells, and they have an inner coating, that is prostacyclin, to keep platelets from sticking. So prostacyclin, you need to know this, okay? Why? Because, you know, everything has a good side and a bad side. Good side is that, suppose there is a cut. Suppose this tissue has a cut, okay? So let's have a cut here. You need platelet plug to come and form clumping and aggregation over there. That's good. You also need a clot to be formed over here so that this area can be sealed up and loss of blood is prevented. However, once the work is done, the wound has healed up, you need to get out. This needs to go, because if it always stays there, it can cause kind of a blockage. That is why you need prostacyclin. Okay, it is antagonistic or opposite in function to aggregation. It will help, you know, wherever they will find prostacyclin, it will keep those channels open. Okay, it will not allow the platelets to stick or to clump like this. When prostacyclin will flow through it, it will separate those and it will not allow them to clump or aggregate. So we need prostacyclin. Aggregation is good, clotting is good, but once the work is done, they need to get out, because we can't have carrying a blood with a lot of clots, and then those clots will, you know, get detached and move to the lungs and cause greater pulmonary embolus over there, forming a clot in the lung. It gets stuck there and it will result in, it has fatal effect as well. So damage to the blood vessel. If a blood vessel is damaged, the platelets would stick to the uneven surfaces in the blood vessels and release their chemicals. Platelets will stick to exposed collagen adhesion. So now you'll find that whenever the tissue has ruptured and or the blood vessel wall is also ruptured, collagen is exposed, and platelets have an affinity for that. They're going to go and stick there, adhere to that collagen. Platelets also break open and release their chemicals. I told you the term for this, that is degranulation. More platelets will stick, and that will form aggregation, and finally they will form a temporary plug. So you are hearing new terms over here: adhesion to collagen, degranulation, that means they are releasing their chemicals, aggregation, that means clumping of more and more platelets together, and then finally they are forming a temporary plug. Hemostasis. So the word hema or hemo means blood, and stasis means to halt or stop the blood flow. So it halts the loss of blood to the walls of the damaged vessels. And it's a cascade. What is a cascade? A cascade is a chain reaction, step by step. Okay, A activates B, B activates C, C activates D, D activates E, and that is a cascade or a chain reaction. And ultimately, it would lead to the formation of a clot and followed by a clot retraction. Okay, once the work is done. So hemostasis has three phases. One is vascular phase, then the platelet phase, and then the coagulation phase. So we come to the clotting at the end. Platelet phase is the plug that I discussed about. Initially, there is a plug, temporary, and just to stop the flow of blood, the loss of blood, and then comes the clotting. So we'll start with the vascular phase. The vascular phase, so cutting the wall of blood vessel, that triggers contraction of the smooth muscles of the vessel. So this is step one. I already told you about the smooth muscles that they contract. So vascular spasm, and this one increases. This sets in. I'll give the arrow up to show that spasm increases. What happens is decrease or diameter of the site of injury. So decrease in the diameter. And what is the purpose? So suppose here is a blood vessel and it is cut. Okay. If you allow it like this, a lot of blood will be lost. So what we are going to do is we are going to do contraction of the smooth muscles and vascular spasm so that the blood vessel will constrict, vasoconstrictor, so that less blood will flow out. That is the purpose. And changes happen to the endothelium of the vessel at the injury site, and endothelial cells contract and expose the basement membrane. What is endothelial cell? What is this cell? It is the endothelial cell of the blood vessel I'm talking about. And once it is cut, it's going to expose the basement membrane, and endothelial cells start releasing chemical factors and local hormones. Again, they're going to discharge these chemicals and hormones. What are they? ADP, tissue factor, prostacyclin. We already discussed about prostacyclin, but here prostacyclin will come into picture later on. Once the platelet plug is done and the clotting is done, later on it will come into action. Initially, it will be ADP, tissue factor, endothelins, that is a peptide hormone. All these are discharged as soon as there is a cut. Some of these local hormones will stimulate the smooth muscle contraction, and they will cause the vascular spasm, and they will stimulate the repair process. Okay, how the repair process will happen? By division of more endothelial cells, by differentiation of more endothelial cells. So a tissue has been cut. There is loss of these cells. So now to replenish those cells back, bring it back, there will be differentiation and division of the cells. And endothelial plasma membranes become sticky. And why is it important? It becomes sticky because it's going to attract more endothelial cells to come and aggregate there. And it will allow the platelets, it will attract the platelets to come and stick over there so that they can form a platelet plug. So vascular phase is the first step. Then comes the platelet phase. So for the platelet phase to kick in, this one becomes sticky so that it can attract the platelets to come. So first step, let me show you. Here's a blood vessel and we have a cut. Okay, so what all changes are going to happen over here? You'll find that the smooth muscles, first number one, the smooth muscles will contract and try to narrow down or constrict. Okay, and so vasoconstriction will happen. It will try to narrow down the blood vessel to stop the loss of blood. You'll find also a lot of chemical factors and local hormones are discharged, like ADP and tissue factor and endothelins. They are released. You'll find for triggering the repair process, more and more endothelial cells will differentiate. And these endothelial plasma membrane will also become sticky because it is going to attract platelets to move there. Okay, they're going to trigger the clotting process to begin, or the formation of the platelet plug to form, so it will make its environment sticky. Once that stickiness sets in, we can go into the platelet phase. So as soon as the endothelial cells are welcoming the platelet cells, now you see attachment of platelets to sticky endothelial cells, to basement membrane, and it starts the platelet phase. So the first phase, in the vascular phase, the endothelial cells and the plasma membrane, they make themselves welcoming so that platelets can come and stick to them and form an aggregation. Okay, so now the platelets will attach to the exposed surface, and that is called adhesion. That's called adhesion, and then aggregation will follow through, and then platelet plug will be formed, and that will close the break that had formed in the vessel wall if the damage is not severe, because if it is severe, platelet plug would not be successful. So platelets arrive at the injury site, they get activated, that means their cytoplasm will swell up, and platelets will release ADP that helps in aggregation, thromboxane A2, serotonin is released that stimulates. Wherever you will find serotonin, that will cause vascular spasm, vasoconstriction, trying to fill up that gap. Clotting factors, proteins that help clotting, those are released. PDGF, that is platelet-derived growth factor, that is released. Why? Because it is going to cause vessel repair. Calcium ions, that will help in aggregation, and calcium is always important in clotting. So that is why all of these are released by platelets. So platelets arrive at that site, cause adhesion to the broken area of the endothelium, adhesion, aggregation, more and more come and aggregated, activated, discharge these chemicals and ions and hormones and enzymes, and platelet plug is formed. Okay, and platelet plug is formed. Now, do they continue to do it? No, there is control and there is restriction. And I told you that a platelet plug or a clot is always not good. So that is why we have prostacyclin as a counter effect that will prevent the platelet aggregation. And that is also released by endothelial cells. So there are other inhibitory compounds that do not allow it, like there are other plasma enzymes. And serotonin also will start blocking the action of ADP, because ADP does a lot of aggregation, platelet aggregation, inviting other platelets to come and form a clump. And serotonin will block it, and that reinforces plug, but it isolates it from the blood circulation. So ultimately the purpose is, plug is good, clotting is good, but staying there permanently is not good. Once your job is done and the tissue is repaired, we don't need you there. We go to the coagulation phase. So this is the third phase, and this is the final phase, and this is the most important phase. It involves extrinsic, intrinsic, and common pathway. So extrinsic, that begins outside the bloodstream in the vessel wall, and especially in the tissues. And then intrinsic begins inside the bloodstream with activation of circulating proenzyme. So by the term extrinsic, you know, external, intrinsic means internal, inside the bloodstream. Both pathways converge at the common pathway. And then clotting depends on number of clotting factors, procoagulants in the plasma. Calcium plays a very important role. So if you do not have sufficient calcium in your body, or for some reason you are losing calcium due to osteoporosis or something, then you will find that the clotting process is affected. And there are 11 other proenzymes. Why we are calling them as proenzyme? Because they are in the inactivate state. We're going to activate them, and so that they can trigger the clotting process. So again, to go through this whole process, how do we stop bleeding? Hemostasis, or halt the bleeding or stop the flow of blood. Vasoconstriction plays an important role. Serotonin does that. Formation of a platelet plug, that I already explained, how adhesion, aggregation happens, and the discharge of those chemicals through degranulation. Then finally, we are going to talk about the fibrin clot, or the fibrin clot. So vasoconstriction of the blood vessels, that is done by serotonin. I explained in the stage 2. We talked about the platelet plug. I spoke about adherence. This is just a summary of all that we discussed. Break open, we release ADP, thromboxane, and aggregation. Plug, look at the word temporary. Why I say temporary? Because after its work is done, it's no longer needed there. Then fibrin finally happens. A clot is formed in the coagulation stage. Clot retraction. The fibrin strands pull and form a tight threads and presses serum out to reduce bleeding and allow the tissue repair. That is the clot retraction process that sets in after the clot has formed. So these are the steps: vascular spasm, then plug formation, and finally the chemicals are released here, and then coagulation. We finished up to this. Let's go to the last step, that is coagulation. So role of platelets, again, platelet addition, prostacyclin, it will not allow the aggregation or the clumping. I already discussed that. Release of platelet chemicals, who all are released: procoagulants, certain clotting factors, chemokines, attraction of neutrophils and macrophages to the site of inflammation. Some growth factors are released. Then clot dissolving enzymes, vasoconstrictors, serotonin. All of these are present in the platelets and the work of platelets. So platelets have too much of work. They make the plug, they remove the plug. They initiate the plug, they attract the clotting to happen, they give the factors that play a role in clotting. So platelets are very, very important. And the vascular spasm, that is the vasoconstriction, injury to smooth muscle of blood vessel causes vasoconstriction, and serotonin released by the platelets. The whole purpose is to minimize the loss of blood, because you are trying to constrict and fill up, minimize the wide open blood vessel. You're trying to bring it together to close the gap. Platelet plug formation. This slide is just repeated. We already discussed about it. I already told you about prostacyclin, and that prevents platelets from aggregating or attaching to each other. Okay, I also told you that broken blood vessels, they have exposed collagen and they get attracted to the collagen and come and stick there. We discussed about when degranulation happens, what all are released: serotonin, that does vasoconstriction, ADP, that causes more and more platelets to attract and come there, and then thromboxane, that stimulates the platelet degranulation and aggregation, release of those chemicals that attracts more platelets to come. Now, coagulation, formation of a permanent clot. You see that word temporary was used when I talked about the plug, but for clot we are going to use the word permanent. Okay, and it forms an insoluble protein called fibrin or fibrin, and formation of prothrombin activating complex, prothrombinase, happens, and this one converts the prothrombin that is made in the liver into thrombin. And then in the next step, the thrombin, this thrombin that is produced here, acts over here, converting the fibrinogen inactive into this fibrin. The soluble fibrinogen into insoluble fibrin. And then finally, the last step is clot retraction. So it begins with the formation of prothrombin activating complex, and that is called prothrombinase. This is the step one. Okay, and that is going to cause prothrombinase is going to come and act over here. So if you write the equations, you're going to first write how this prothrombinase is coming and converting prothrombin into thrombin. And then thrombin is acting over here, converting the fibrinogen into insoluble fibrin. And this is the clot. We'll look at the extrinsic. So clotting will proceed in two directions, either extrinsic or intrinsic, and they will merge together into a common pathway. We'll see the extrinsic first. The extrinsic begins when damaged endothelial cells or peripheral tissues, they will release factor 3. Factor 3. So each factor has a name associated with it. I'll show you the names in the subsequent slides. So factor 3 is called as thromboplastin. It's very important. So factor 3, that means thromboplastin, combines with calcium ions and then with factor 7 to form enzyme complex that activates 10. Okay, so extrinsic will begin, how it will begin, when you will have the peripheral tissues or the endothelial cells, they are damaged, and the blood already has factor 3 or thromboplastin. When it comes in contact with these injured part, you'll find that factor 3 is activated. Okay, and then it will combine with calcium ions and with factor 7, Roman numbers, and then it will form an enzyme complex. Okay, it will form an enzyme complex, and that is going to activate factor 10. Okay, so this is the sequence of steps, how it proceeds up to factor 10. All that we need is factor 10. So blood already has thromboplastin, okay, or factor 3, and when this tissue is damaged, this is activated in combination with calcium ions and with factor 7, that means 3, 7 enzyme complex, and leads to factor 10. Come to intrinsic pathway. It begins with activation of factor 12 when exposed to collagen fibers at the injury site. So this is happening in the bloodstream, and the extrinsic is outside in the tissues, peripheral tissues. So this one, that's why this is intrinsic or internal. So when the injury is internal, you'll find that as soon as the injury happens, as soon as the injury happens, who is activated? Factor 12 is activated. Okay, and it is exposed to the collagen fibers at the injury site, and that triggers it. Then platelet factor 3 is released by the aggregating platelets. Immediately there is aggregation of the platelets. Excuse me. So when there is aggregation of the platelets, platelet factor 3 is released, and that will activate factor 8 and 9, and then they combine to form an enzyme complex, and that will activate 10. So we have 12, factor 12, platelet factor 3 also helps. Then we have 8, we have 9, and they will form enzyme complex, and that will lead to ultimately factor 10. All that we need is factor 10. So the previous one, extrinsic, is 3, 7, enzyme complex 10. Intrinsic is 12, 8, 9, enzyme complex 10. Both of them end up in 10. Now we come to the common pathway. When enzyme complexes from either pathway activate factor 10. So we have extrinsic, we have intrinsic. Okay, so extrinsic is coming like this to ending up at factor 10. Intrinsic is also coming this way, ending up at factor 10. Okay, activated factor 10 activates prothrombin activator. This prothrombin activator converts prothrombin into thrombin, and then thrombin converts fibrinogen into fibrin, and that is the clot. So there is a picture which I can show you where extrinsic comes, intrinsic comes, they activate factor 10, that activates prothrombin activator, that converts prothrombin into thrombin, thrombin is activated, that converts fibrinogen into insoluble fibrin clot. So extrinsic versus intrinsic, and remember extrinsic is always faster because less number of steps are involved also. And what are the factors? So to initiate the clotting, damaged endothelial cells of the vessels or peripheral tissue, and that tissue damage where blood escapes from the vascular system. Generally both work at the same time, so you will have extrinsic and intrinsic working together, and that will lead to the common pathway being triggered and leading into clotting. So here is the detail. The terms that are used: factor 1 is fibrinogen, 2 is prothrombin, 3 is tissue thromboplastin, we also call it as tissue factor, 4 is calcium, and then 5 is labile factor or proacceleratin. You don't need you don't have to remember all of these names. Hageman factor is 12. That's the path of intrinsic pathway. And then we use the term TF for tissue factor. A means activated form, PL means platelet membrane phospholipid. Okay, so look at intrinsic, 12. So first it comes in contact with the collagen fibers of the injured area. So 12 is converted into 12A, activated. 12A converts 11 into 11A. A means activated. 11A will convert 9 into 9A. 9A in association with 8 platelet factor and the calcium ions will convert 10 into 10A. We stop here. Look at extrinsic, the tissue damage. Okay, you'll see 7A tissue factor is coming in this pathway. Factor 3, factor 7 comes to factor 10. Now, right over here, 10 is converted into 10A. If you come through the intrinsic pathway, 10 is converted into 10A. That means they activated. And in the presence of these factor 5, platelet factors and calcium, prothrombin is converted into thrombin. Okay, and then thrombin converts the fibrinogen into fibrin. And finally, 13 is converted into 13A, and it helps fibrin become a stable fibrin clot. Either it moves in this direction, so thrombin converts this 13 into 13A. I do not expect you to draw this or write down it or memorize it, but at least you should know that both of them end in factor 10. That is important. You should know that. You should know that prothrombin is converted into thrombin, and then thrombin converts fibrinogen into fibrin. That is the clot. Okay, so some steps you should remember. You should also remember about intrinsic, that 12, 8, 9 lead to the factor 10. And if you look at extrinsic, 3, 7 lead to factor 10. Okay, and then the common pathway, prothrombin is converted into thrombin. Thrombin converts into fibrin. So if you look at this diagram, if there is a tissue damage, factor 3, factor 7, factor 10, that is extrinsic. If you look at intrinsic, where they're exposed to the internal blood vessels damage and exposed to the collagen fibers, you will find it's moving in this direction, starts with 12, 8, 9, 10. Fact, all end up in factor 10, both pathways. Then common pathway, prothrombinase converts prothrombin into thrombin. Thrombin will convert fibrinogen into fibrin, and a clot is formed. So once the clot is formed, as I told you, we're not going to keep the clot completely with us. It's harmful. It might get dislodged and it might go into the lungs and cause other issues there. So when the blood vessel is repaired, the clot will dissolve. And who does that? So plasminogen is converted into plasmin by tissue plasminogen activator. And this plasmin that is formed, it is an enzyme that breaks down the fibrin and converts into the soluble form, that is fibrinogen. So the insoluble fibrin is converted into the soluble fibrinogen, and that's how we get rid of the clot once the tissue has repaired. Now, feedback control. So thrombin generated in the common pathway, it stimulates the blood clotting. So we see the king of all of these processes is thrombin. We cannot do the clotting without thrombin. And by stimulating the formation of tissue factor, stimulating the release of the platelet factor 3 by platelets. And this positive feedback loop accelerates the clotting process. So how it actually keeps it like happening as a loop, as reinforcing the mechanism. Positive feedback means it is reinforcing the entire mechanism. Clotting is restricted by deactivating or removal of the clot factors. So antithrombin 2, it will inhibit the clotting factors. Okay, heparin released by the basophils, and as you know, heparin is an anticoagulant. It will not allow the clotting to happen. Thrombomodulin that is released by the endothelial cells binds to the thrombin and converts it to protein C, and that activates the formation of plasmin, and then plasmin will break the fibrin. Okay, so once the work is done, the clotting process has been completed, these are the agents or the elements that will help in clot removal or dissolving the fibrin. Heparin is one of them, thrombomodulin is one of them, and ultimately it will lead to the formation of plasmin that will break the fibrin. There are drugs to stop clotting like heparin that blocks thrombin. There are blood thinners as well. These are the names that stop, like if you're going for a surgery, the doctor will tell you if you are on blood thinners, then you need to stop the blood thinners before you go for the surgery, because you need the clotting to happen after the surgery. The blood thinners would prevent it. Vitamin K antagonists are needed to form several clotting factors. So if you are not taking, if you are having a problem with vitamin K in your body, then you would find that the clotting is affected. And then tissue plasminogen activator, that is also needed to convert plasminogen into plasmin so that it will dissolve the fibrin clot. Preventing the inappropriate clotting. So sometimes there is platelet repulsion, and that is done by prostacyclin. We already discussed about prostacyclin. It does not allow the aggregation of the clotting. And then dilution, flow of blood dilutes thrombin, from forming spontaneously suddenly. And we have heparin also, that is an anticoagulant and antithrombin that is produced by the liver. So if you fall short with these things, then you have more tendency to form clot inside the body. And if you are having obesity and cholesterol, that's even a deadly combination when you are having difficulty. If you're not balancing your food well, then cholesterol will form plaque, and then if it will rupture the blood vessel, and then the clot will form over there, that could lead to an effective blockage. So clotting disorders happen in these cases. Hemophilia, that is a type A or B or C von Willebrand disease. These are the situations. Or hematomas are formed, massive blood clot, or thrombosis, small blood clot. And then, these clots have a tendency to detach sometimes, and they go to the lungs, that is embolus. So that's all. So embolus definition, piece of a thrombus that breaks off and then it travels in the bloodstream, lodging itself in a small vessel. So all of these happens when there is a clotting disorder. So a clot was supposed to create or seal a wound, but then it detaches and it migrates some other location and causes a blockage there. So that is when it becomes deadly for that person. So that finishes off this chapter on blood.